Good day. We are the group 4 and we are going to discuss about ectopic pregnancy, its etiology, risk factors, clinical manifestations, management, pathophysiology, and midwifery role. I am Lovely Tolentino Subia from BSM 2B and I will discuss to you about ectopic pregnancy. First, what is ectopic pregnancy? Ectopic pregnancy is also called extra-uterine pregnancy. It occurs when a fertilized egg grows outside of the uterus. Ectopic pregnancy occurs when a fertilized egg implants and grows outside the main cavity of the uterus. And also it occurs in the fallopian tube, which carries eggs from the ovaries to the uterus. Next, etiology of ectopic pregnancy. Ectopic pregnancy is often caused by damage to the fallopian tubes. Second, a fertilized egg may have trouble passing through a damaged tube, causing the egg to implant and grow in the tube. Third, things that make you more likely to have fallopian tube damage and an ectopic pregnancy include smoking. Indicates that happens when a fertilized egg gets stuck on its way to the uterus, often because the fallopian tube is damaged by inflammation or is mishappened. Next, risk factors of ectopic pregnancy. First, previous ectopic pregnancy. Previous ectopic pregnancy, women who have had one ectopic pregnancy are around 17 times more likely to have an ectopic pregnancy than a woman who has not had an ectopic pregnancy. Second, prior fallopian tube surgery. Anatomically, abnormalities of the fallopian tubes can make implantation in the tubes much more likely than in women without tubal abnormalities. Third, previous pelvic or abdominal surgery. With the possible exceptions of ruptured appendix, abdominal surgery that does not directly involve the fallopian tubes has little or no influence on the occurrence of tubal pregnancy. Fourth, certain sexually transmitted infections. Women who had chlamydia or the greater risk of an ectopic pregnancy because of a lasting effect of the infection. According to the new research, a study by an Edinburgh University experts has shown for the first time of how the sexually transmitted infection can increase the risk of ectopic pregnancy. Fifth, pelvic inflammatory disease, endometriosis. PID is a major cause of tubal ectopic pregnancy. An ectopic pregnancy can occur when untreated PID has caused scar tissue to develop in the fallopian tubes.
I am Elsie Sagapan from Group 4 and I will discuss the clinical manifestations of ectopic pregnancy, the signs and objectives. An ectopic pregnancy can cause your fallopian tube to burst or rupture. Emergency symptoms include major pain with or without severe bleeding. Early signs of an ectopic pregnancy include light vaginal bleeding and pelvic pain. If blood leaks from your fallopian tube, you may feel shoulder pain on an urge to have a bowel movement. Next, upset stomach and vomiting. An ectopic pregnancy can cause similar symptoms to a gastrointestinal disease and is often associated with upset stomach and vomiting. Sharp abdominal cramps. A ruptured fallopian tube can cause life-threatening internal bleeding, and abdominal pain may become severe and sharp. Next is pain on one side of your body. You may experience tummy pain, typically down on one side. It can develop suddenly or gradually and may be persistent or come and go. There is also dizziness and weakness, and also pain in your shoulder, neck, or rectum. Another clinical manifestation is symptoms or subjectives. A missed period and other signs of pregnancy. An ectopic pregnancy doesn't always cause symptoms and may only be detected during a routine pregnancy scan. Next, tummy pain low down on one side, like breast tenderness and nausea. If you take a pregnancy test, the result will be positive. Still, an ectopic pregnancy can cause or can continue as normal. Vaginal bleeding or a brown, watery discharge. In rare cases, brownish-pink discharge can be caused by an ectopic pregnancy. The brownish color occurs because the bleeding is older blood, not bright red or new blood. Next is pain in the tip of your shoulder and also discomfort when peeing or pooing. But these symptoms aren't necessarily a sign of a serious problem. They can be sometimes be caused by other problems such as stomach bug. Next is the pathophysiology of ectopic pregnancy. Due to the formation of trophoblast, the zygote is implanted in the tubular wall and began to produce HCG, which maintains corpus luteum, wherein the corpus luteum produces estrogen and progesterone required for uterus enlargement. Tubal pregnancy does not develop beyond 8 weeks due to poor vascular supply. Ectopic pregnancies are dangerous. Any growing pregnancy require a lot of nutrient source and develop many communications with the mother vascular system. Next is thin wall, narrow lumen, and lack of decidual reaction in the tube. Decidual reaction is an exaggeration of the normal response of the endometrium to progesterone. In the absence of pregnancy, ectopic decidual changes have been attributed to the stimulation of appropriate cells by progesterone and progesterone-like substances from the corpus luteum or adrenal cortex. Any abnormality in tubal morphology or function may lead to ectopic pregnancy.
Good afternoon, I'm Elisa Sumalag, BSN2B. I will report the management of ectopic pregnancy. So before I start, let me give you a brief definition of what is an ectopic pregnancy. So ectopic pregnancy happens when a fertilized ovum is developed or implants outside the womb or the uterus of the mother. Now let's move to the management. An ectopic pregnancy may be managed surgically, medically, and expectantly. But my report is just the surgical and medical management. So, what is the medical management? Medical management is an umbrella term that encompasses the use of IT for health, diseases, care, and case management functions. So, this is useful for patients with an unruptured tubal ectopic pregnancy who are hemodynamically stable and have minimal symptoms, and a low volume of free intraperitoneal fluid on ultrasound scan. So, what is unruptured tubal ectopic pregnancy? This is the lack of awareness of early pregnancy, late reporting by women to healthcare facilities when aware of pregnant, and this is failure of healthcare providers to utilize the diagnostic aids for detecting unruptured ectopic pregnancy. So this is why the health education is encouraging all women to attend clinic early in pregnancy, especially when they are experiencing unusual symptoms of lower abdominal pain and irregular vaginal bleeding. This could help in the diagnostic of unruptured ectopic pregnancy. So, we have the following inclusion criteria for the medical management of ectopic pregnancy with methotrexate. So, what does methotrexate mean? Methotrexate Methotrexate is the most common drug used to treat ectopic pregnancy. This drug stops cells from growing, which end the pregnancy. Because of this, the removal of fallopian tube is not required anymore. So, let's go to the patient characteristic. The patient characteristic include if they would prefer medical options, if they were willing to attend follow-up for up to 6 weeks, or if they're willing to abstain from alcohol for 7 days following the treatment, and not breastfeeding or willing to stop. Next is the clinical features. Includes the hemodynamically stable and the minimal abdominal pain, and the ultrasound scan findings, such as no fetal heart activity or clear yolk sac in adrenal mass, small amount of free fluid, and unlikely to be early intrauterine pregnancy failure. Serum beta human chorionic gonadotropin is a concentrations usually less than 3,000 international unit per 1, although limits of less than 5,000 international unit per 1 are used in some units and earlier studies. Treatment success lower limit applies. And next is the medical history of the patients. Must include no active peptic ulcer disease, no severe medical conditions including renal disease, hepatic disease, severe anemia, leukopenia, or thrombocytopenia. Last is should not be an occurrent medication. Must include the non-steroidal anti-inflammatory agents, aspirin, penicillins, sulfonamides, trimethoprim, tetracyclines, diuretics, phenytoin, anti-malarials, cyclosporin, retinoids, probenecid, folic acid, hypoglycemics, live vaccines, hepatotoxic or hepatotoxic drugs. So next is surgical management of ectopic pregnancy. Surgical is imperative in the clinical scenario of a ruptured ectopic pregnancy. Surgical is contrary with a medical. Surgical is ruptured while medical is unruptured ectopic pregnancy. So what is ruptured ectopic pregnancy? Ectopic ruptured pregnancy happens when the fallopian tubes can break if stretched too much by the growing pregnancy. That can cause internal bleeding, infections, and in some cases lead to death. So a laparoscopic approach is preferable to an open approach in a patient who is hemodynamically stable. Laparoscopic procedures are associated with shorter operative times, less intraoperative blood loss, shorter hospital stays, and lower analgesia requirements. So, laparotomy should be reserved for patients who present with ruptured and are in a state of hypovolemic shock and compromise. If the contralateral tube is healthy, the preferred option is salpingectomy, where the entire fallopian tube or the affected segment containing the ectopic gestation is removed.
Midwifery role, independent. Midwives and nurses are often the first part of call for a woman, and therefore the importance of understanding the signs of symptoms of ectopic pregnancy to ensure prompt referral and accurate advice is essential. So, the independent role of a midwife regarding an ectopic pregnancy is that by knowing the signs and symptoms of ectopic pregnancy for them to know if they will going to refer it to the doctors or other medical practitioners that are more knowledgeable or skillful in this field. So the midwife can give advice or inform the patient about the risk factors of having ectopic pregnancy, or they can do or they will do counseling women regarding the ectopic pregnancy on how they can handle it or how they can manage this ectopic pregnancy. It is important to explain it well to the patient for them to be aware on what will be the process that will be undergone.
Dependent doctor's order. To find out if you have an ectopic pregnancy, your doctor will likely do a pelvic exam to check the size of your uterus and feel for growths or tenderness in your belly. A blood test that checks the level of the pregnancy hormone, HCG. This test is repeated 2 days, and ultrasound. During early pregnancy, the level of this hormone doubles every 2 days. Low levels suggest a problem, such as ectopic pregnancy, which is yung ultrasound. This test can show pictures of what is inside your belly. With ultrasound, a doctor can usually see a pregnancy in the uterus 6 weeks after your menstrual period.
Collaborative or referral. An ectopic pregnancy cannot be diagnosed in the community, meaning that is the key to ensure that the patient is referred promptly to an early pregnancy assessment unit when any signs and symptoms of ectopic pregnancy are displayed. It's essential that a midwife has an understanding of the signs and symptoms in order for prompt and appropriate referral. Understanding the signs and symptoms of ectopic pregnancy is really important. The midwife must know this or master it to avoid mistakes. If the midwife already knows the signs and symptoms of ectopic pregnancy, he or she must refer it to the doctors or other medical practitioners to avoid high risk and big harm to the patient, and for early treatment for the patient. If the midwife is not doing her role, it is expected that the patient is in high risk. Ectopic pregnancy is a serious condition, so it must be treated immediately to lessen the mortality of mothers due to ectopic pregnancy. So, understanding the signs and symptoms of ectopic pregnancy is really important to lessen the risk factors for the mothers or for the patient.